Okay, well, I think what we'll do is, about a minute, I will introduce the speakers, and then we'll move on from that. But to give people just a short while longer to connect. I'm really looking forward to today's talk. I had the good pleasure to work with Nancy for a long time, and I'm very aware of all the great work she's been doing, especially in Haiti. So I'm looking forward to hearing an update on that. So I'll just introduce the two speakers. So Nancy Puttkammer is an assistant professor in the Department of Global Health at the University of Washington and faculty co-lead of the Digital Initiatives Group at ITEC, that's the International Training and Education Center for Health, which is a long-standing group that's done a lot of international health and global health informatics work. Dr. Puttkammer is trained in health services research, specializing in using observational, routine collected data from electronic health records to strengthen HIV care and treatment programs. And she works with health informatics and training projects in Haiti, Kenya, Ukraine, and other settings, particularly to improve national health information systems and evaluate data quality and data use, and support data analyses and develop capacity for data use and implementation science research among colleagues and counterparts. And we've worked together over the years, particularly on the aspects of evaluating health information systems and electronic health records, and are perhaps unusual in really caring about data quality. Is that perhaps fair to say, Nancy? That it's such a critical issue that affects so much of the work we do in any really area of health informatics, but particularly in international health contexts, and really focusing on how to monitor and improve that has been a key thing. And she's worked in public health programs in the US, Africa, and the Caribbean for more than 30 years. So we've both been at it for a long time. Tracy Sandifer is an epidemiologist interested in the application of machine learning to health information systems for clinical and public health goals in surveillance and optimization of services. And she's led design, development, implementation, and evaluation of several large multi-source population-based health information systems in the US and internationally, including Malawi, Botswana, Zimbabwe, Ukraine, India, and Haiti. So in both cases, we've got speakers who have an understanding of what it actually takes to implement the systems, as well as how to use the data from those systems. She's particularly interested in analytic methods that explicitly examine bias, fairness, and multiple perspectives of utility, and aim to foster conversations among diverse stakeholders about how machine learning can best enhance the skills of people. And so again, in this work, there's obviously really important to understand how the data we're collecting actually represents the populations in question, and whether models that are developed from that data can really be effective. So with that, I will stop speaking and hand it over to Nancy and Tracy.
Great. Thank you so much, Hamish. We're very happy to be here in this Zoom world. That we can be with you at Brown University is really wonderful. So thank you to Hamish and Brown colleagues for inviting us here. The title of our talk is Applying Prediction Models for Clinical Decision Support Within a Real-World EMR in a Low-Resource Setting. We'll be speaking with you about work with Haiti's iSanté EMR system in terms of supporting differentiated HIV care, but with an eye to more generalized methods that could be used more broadly in such routine health information systems. Tracy and I will be trading off talking, and Tracy will start us off, and then I'll present a study that we completed in Haiti, and then Tracy will talk about ongoing work that she is leading. So take it away, Tracy.
Thank you, and thank you for the introduction, Hamish. The quick overview of our talk, a little bit of a teaser about the breadth of prediction models in routine health information systems in low and middle income countries. As Nancy mentioned, she'll talk about some published research work, and I'll talk about some methods. So My particular view on work in LMICs might be a little bit novel, but I see it as a learning lab for methods that are pretty broadly applicable. This diagram is from a systematic review of prediction models trained on data collected in low and middle income countries, and it's specific to pediatric mortality while in hospital. And so just to highlight a couple of the similarities and differences, so this systematic review covered 21 publications after reviewing thousands of potential. And this is pretty typical of trying to review prediction models because the word predictor is so common. You have to review quite a lot of results to see what is actually a prediction model as opposed to a study of factors associated with a given outcome. So what's similar is the approaches people are taking, the language people are using, and really the nature of the models themselves. The methods used in these papers look very similar to the prediction models from anywhere else. Most of the predictors studied in these models look quite similar, except I will note that the distribution of some factors such as malnutrition or undernutrition would certainly be more common in some settings than others. And then some of the data quality challenges are quite a bit more pronounced in LMICs than other settings that we're used to seeing. But I'll also quickly introduce the idea that from having participated in US public health during the scale up of meaningful use policy under the Affordable Care Act and watching small shop clinical practices, single doctors in later stages of their life who had always had paper health record systems coming online for the first time, seeing the processes they went through to get their data into systems, looks very reminiscent to me of the kind of work we do here. So I'll just put that teaser out there for the methods we'll talk about later for data quality and really examining assumptions in the data are pretty universal. So the few examples I've given here of prediction models in clinical use, there is quite a lot of need for prediction models for settings where there is not as much availability of healthcare professionals or specialists as one would like. So there's the promise that some clinical decision support tools that are driven by prediction models may assist in those settings. There is quite a lot of need for locale-specific detection of diseases that have really focal transmission patterns. Malaria jumps to mind. And also optimizing, predicting and preventing missed appointments, especially when the outreach for this might involve having a healthcare worker walk to someone's house and try to re-engage them in care. Those sorts of models have less of promise in these settings. And I'll also mention there is a really strong body of work in what I think of as health adjacent, but definitely health critical domains of natural disasters and agricultural management. The prediction of earthquakes and floods, the prediction of waves of pests, the prediction of fungal diseases of plants, all of these are of huge importance to a lot of these settings as well. So with this, I'll turn it back over to Nancy.
Great. Oops. Okay, no echo there. Okay, I'll be speaking with you about this study called Info Plus Adherence that we carried out in Haiti. This is a publication that came out last year that summarized the results of the study. And just to situate it in terms of that nice introduction that Tracy gave, we were focused on improving HIV care and treatment and focused on improving antiretroviral therapy or ART adherence in patients by trying to target the patients who were, through a prediction model, who were most likely to experience future treatment failure, to target them for intensified ART adherence counseling. So next slide.
I'm so sorry, but I'm having trouble advancing slides sometimes, and I don't know why.
Okay, thanks, Tracy. If it persists, we could do a rapid shift and I'm ready to share if needed. Okay, great. So just a little bit of background on Haiti. Hamish mentioned that he and I have both done extensive work there and had the pleasure of working together there. So Haiti, just a 2-hour flight from Miami in Florida, is a beautiful, vibrant country that is also the poorest country in the Caribbean region, with tremendous health challenges. You can see some of the background statistics there on Haiti. In terms of the HIV epidemic, Haiti does have a generalized epidemic with adult prevalence of about 2% at the last estimate, based on a household survey, with higher HIV prevalence among women than among men. Next slide. Great. So this shows what we call the HIV Care Cascade in Haiti. I'm not sure if participants here are immersed in HIV programs, but we talk about the UNAIDS 95, 95, 95 targets to achieve HIV epidemic control. And this means that 95% of people living with HIV have known diagnoses, that 95% of those are started on treatment, and among those started on treatment, that 95% will achieve viral suppression. And this is the key to really turning back the HIV epidemic. So this shows along this cascade the gaps that Haiti that still remain for Haiti to achieve these UNAIDS 95, 95, 95 targets. There has been incredible investment and tremendous progress through very challenging conditions to achieve these results so far, but we can see with the bar at the furthest right that only 48% of people have known achievement of viral suppression. So quite a bit more to go before we get to those targets. Next slide, please. Oops. Yeah, so this shows just a little bit of context about the ART program in which we were situating the intervention that I'll describe. So the HIV treatment scale-up began back in 2004 in Haiti at larger scale. Of course, there had been some tremendous work that actually Hamish and partners and health colleagues had helped lead in Haiti that really demonstrated that HIV treatment could be successful in resource-limited settings. That began in the 1990s. But by 2004, there was influx of funding from Global Fund and PEPFAR to really scale up treatment. And then since then, it's all been about really trying to optimize the program, expand access to treatment. We can see 2 steps here in 2014 with the Option B Plus initiative, and then in 2016 with Test and Start, these big policy shifts that really expanded access to all patients, access to treatment to all patients who are living with HIV, and then various efforts along the way to minimize the barriers that patients would face in continuing with their treatment. So moving distribution of meds out into the community, or providing these multi-month dispenses of ART so that patients wouldn't have to, leave work or take time away from their income generating activities to come into the clinic to get their refills of their meds. Next slide, please. Our intervention and the work that we'll be talking about is situated in the context where there has been tremendous investment also in the health information systems for the HIV program. Our group has been involved in implementing an electronic medical record, or EMR, in Haiti in more than now 140 sites in the country, so covering much of the country, covering about 80% of all the patients on ART in the country. This is the iSanté EMR. And then there are several sites through Partners in Health and a local non-governmental organization that are covered through other EMR systems. But basically, there's been a tremendous investment in these routine EMRs in Haiti for the purposes of HIV programs. Next slide. Okay, so here's again our study. Next slide, please. So the aim here was to develop and evaluate this Amphoplus adherence intervention. This was funded by the National Institutes of Mental Health as an R34 study, so a 3-year pilot study. And I led this along with my colleague Jane Simoni from the Department of Psychology here at University of Washington. Jane is an expert in ART adherence. And we actually collaborated with Dr. Ira Wilson at Brown, who is really an expert in HIV programs and in patient-provider communication to improve HIV treatment outcomes. So this intervention had 2 components to it. The first was this clinical decision support piece, this EMR-based alert that again was signaling patients at high risk of treatment failure before that failure occurred. This alert was based on a fairly simple prediction model that we had tested and that Tracy really helped to work on. Very straightforward model that drew on socio-demographic characteristics, on basic clinical information. And what this was responding to was that in investigating the data in the EMR, we could see that the patients who were most likely to get ART adherence counseling were actually the patients who were doing the best, that somehow the providers were targeting the patients who were kind of easiest to reach and not those who actually were most at risk of treatment failure, who really needed the counseling. So we wanted to put this alert in front of them to say, you know, here's a patient at high risk, focus your energy here in terms of the counseling and the adherence support that you deliver. So that was the EMR alert. Then the second part of this was a counseling approach that we called My Adherence Stories. This was a brief counseling approach that was provider-led. And basically what this was oriented around was that in our formative work, we realized that often ART adherence counseling was not provided by the doctors and nurses, or maybe it was provided kind of one time at the beginning of treatment, but then not sort of reinforced thereafter. And when it was provided, it was often from very much a one-way kind of lecture-based approach, like your meds are so important, you must take them, you know, sort of kind of really just encouraging or sometimes even kind of haranguing the patients that they must do this, but not so much a problem-solving approach. So these were the 2 components of the intervention, and we felt it was novel and significant because it was introducing predictive analytics again into this routine EMR system. We've seen a lot of work, as Tracy was mentioning, around prediction models, but less work about those models actually being implemented in practice in LMICs. So that was a novel component of this work at that time. And then we felt like this pairing of the data system with the theory-based counseling approach was another novel aspect. Next slide, please. So here's what the alert looked like and involved. Again, in most of those sites we showed you on the map using the EMR is actually used at point of care. So the patients, if you can go ahead and click, Tracy, the providers rather, they'll open a patient cover page and see the summary information. And we included this alert there at the top in the section around alerts with a sort of traffic light oriented you know, red, yellow, green spectrum of risk. They could then click on that alert, and this would open a pop-up window that would show how this patient's risk evolved over time in the last 6 months, and would show days when, based on the ART dispensing information, the patient may not have had medication in their possession. Then it would allow the providers to enter information about their adherence counseling and to see prior comments from other providers about their conversations with the patients. Maybe they would be noting adherence challenges or plans to improve adherence. Go ahead, Tracy. Thanks. Yeah, so then we had this job aid that gave the health workers these sort of scripts to introduce the color codes. The blue category was patients who had known suppressed viral load results in the last 3 months. The red category was known known cases without viral suppression. And then the green, yellow, and dark orange there were these prediction-based levels of risk driven by the prediction model when there was no recent viral load test result available. And what we were doing here was showing that, depending on the person's color code, you're going to give different messages. You're going to talk with them in a different way about their adherence and their risk. It ended up that the providers really liked this job aid, and they ended up putting it around the clinic, putting it up on the walls, and the patients became quite intrigued and very interested in learning about their color code status. So that was a little bit unanticipated, but something that was quite interesting. Go ahead. Thank you. So here is the counseling approach, this 5-step problem-solving based counseling approach, where we first would introduce that medication, taking meds every day is not necessarily easy, kind of set the norm that this can be challenging. Again, what we had found in the formative work was that patients tended to, out of probably social desirability, wanting to, please the providers, tended to say, oh yeah, I've taken all my medicine. And so this kind of set the norm that it can be challenging. Let's really talk about your challenges in an open and honest way. Then the next step is to explore the patient's motivation, then to dive into their personal experience with taking their meds. This was this My Adherence Stories counseling approach that was kind of a culturally adapted counseling approach, recognizing that Haiti is a very verbal culture, a very storytelling culture. So asking patients to tell me about a good day when you were able to take all your medicines, and tell me about a bad day when you were not able to take all your medicines. Then we move into, in a patient-centered way, this problem analysis. What made it hard to take your meds on a bad day? What helped on the good day? And then finally, the working with the patient to identify a solution that they wanted to work on for overcoming their adherence challenges. So here was the study procedures for this 3-year study. I mentioned that we completed the formative work, including both qualitative interviews with patients and health workers, as well as the algorithm and alert development. Then we carried out a pilot trial. This was a small-scale study based in 2 ART clinics. One was randomly selected to be the intervention clinic that was in northern Haiti, and the second site was a control site. We included adults who had started ART within the last 12 months, and they were surveyed at the entry into the study and then again at exit. And then we had their EMR-based data to analyze outcomes. This study was not powered to detect efficacy or effectiveness of the intervention, but it did measure as a primary outcome the viral load, viral suppression, as well as ART adherence and the mechanisms of effect, the patient's information, motivation, and behavioral skills related to taking their ART medications, and then also the patient-provider communication. At the end, we held exit focus group with the health workers to get their feedback on what it was like to implement this intervention and what recommendations they had for improving it going forward. So here are characteristics of the participants. Again, this was a small-scale study. We had 81 participants at the intervention site and 65 at the control site, and you can see some of their characteristics here. Typically had been on ART for a couple of months before enrolling in the study, and had known their status for a little less than a year. Next slide. So this shows the viral load outcomes, and we were able to compare the intervention site to the control site, and also to compare the sites to their own sites in historical EMR records. So the first thing I want to point out is that there was a lot of viral load data missing. There were many patients who did not have viral load results, as we can see the gray bars. The yellow shows the portion of patients who were not suppressed in terms of their viral load, so the negative outcome, and then the blue would be the patients with suppressed viral loads, the positive outcome. We can see that there was a change in terms of improved viral suppression in both the intervention and control sites compared to their historical in the intervention site, there was an improvement compared to the historical period, but no real change in the control site. And in a difference in difference analysis, you can see that the intervention was associated with a favorable result in terms of viral suppression, but this was not statistically significant. And again, with this small study and only 2 sites, I just want to emphasize that we bring very cautious interpretation, both because of the missing viral load results and because of the small scale nature of the study. There could be other things that were going on at the sites that may have explained this result. Next slide. Here's what we saw in terms of the adherence outcomes. This was based on the medication dispensing and this measure of proportion of days covered, looking at did patients return in a timely way to pick up their medications, and therefore did they have greater than 90% proportion of days covered, meds in hand. So we saw here that there was a large association between the intervention and this PDC outcome. Here the yellow is the favorable result, and we can see how it improved more strongly in the intervention site than in the control site, with a very high relative risk of this improved PDC measure. But again, we have to bring a cautious interpretation here, because the intervention, this introduction of this ampho-plus adherence intervention and the counseling approach wasn't the only thing going on that may have explained these results. So next slide. Now I want to just share some of the qualitative feedback, because I think, when we understand that cautious interpretation of the quantitative results, it's also important to understand kind of the qualitative feedback that we got from the health workers. So these were some of the opinions of the alert. The health workers noted that many patients were starting to be motivated by that. I mentioned how they had put up that job aid as kind of almost like a little poster in different parts of the clinic, and they talked about how the patients would mention it. They'd come into the consult room and say, "What's my color status?" and be really curious about it and really motivated by it. They talked about how the patients, it did encourage the more honest, open communication. This one health worker said, "I saw a patient told me he couldn't take his medication regularly, and he could not lie to me because I see everything." And they also talked about how it made it a lot easier to have this alert on the cover page, that there's so much information contained in the EMR, and to have a sense when they opened the cover page about how that patient was doing or what their risk level was a really nice kind of summary in terms of rapidly orienting them to kind of how they needed to focus with this given patient. Next slide. Then in terms of the My Adherence Stories counseling approach, the health workers liked that it helped them use the same language to be consistent across providers in their communication with the clients. They liked, as we mentioned, that it opened up dialogue with the patients and shifted that dynamic from sort of the one-way lecture-based approach towards more of an open discussion. And they talked about how it helped patients feel valued and prepared. Next slide. So we did notice as we looked at implementation and kind of the fidelity of implementation of the intervention, that it was far from ideal in terms of the usage of the alert. First of all, there was this time when the server was out following an electrical storm, and their computers got fried, and it took a while to get somebody out to the site to then set up a new server, so their EMR was down for several weeks. And then we can see that the light gray bars are all the visits in any given week where the alert was visible, where that visible on the patient cover page, and then the black bars being the number of visits where the providers actually clicked and opened that pop-up window and sort of investigated the alert, or noted down information about their counseling. So with viewing it on the cover page, these what we see in the light gray bars, they may have still used it, but we didn't have a way of really telling for every encounter how much they referred to that alert, other than through these dark black boxes or bars show when they actually opened the pop-up. Next slide. Yeah, so just as a summary, we felt like this was a very useful study, again, to really test the implementation of a prediction model and a prediction-based alert in a real-world setting. We found that the health workers had a good understanding of the intervention, though in some cases they did have misperceptions on the factors that were used to drive the alert algorithm. We also found that different health workers reacted differently to the information presented. So we heard from doctors, for example, that they were really curious for more information about what factors for any given patient actually drove their color status. So really being able to dive into kind of more detail at the individual person level, whereas community health workers who really liked the alert, they just wanted to know what the color status was, and they weren't really so concerned with the factors driving it. So this kind of real difference depending on the cadre of the health worker, what they sort of were information they were interested in seeing about the alert. We mentioned that the fidelity of implementation was a little bit weak, that we saw how they weren't always using that alert pop-up, and we noted that sometimes they were very good at using that My Adherence Stories counseling approach, but sometimes didn't always get to the sort of problem-solving portion of the counseling. And then I highlighted already the issue with the missing viral load outcome measures. So yeah, I think that's the overview of the study, and let me transition it back to Tracy to talk about how she's really carrying forward work that builds upon this.
Thanks, Nancy. So this next part of the work that we'll be talking about is funded by a CFAR grant with investigators Nancy, A.B. Flaxman and Marco Caron at the University of Washington, and Jean-Gabriel Ballon with our Haitian collaborator Chares and myself. So the goals of extending the approach to the prediction model that Nancy discussed are a couple-fold. One is to be able to go into greater detail about the predictors for each of these patients and to use more information in the electronic health record system. The iSanté electronic health record system has been in use for quite a long time and is very robust and has a lot of great information in it that is quite difficult to get at. So trying to extract and examine the potential for using more of that information, and then to potentially see if prediction models could also be used for targeted viral load testing in addition to the targeting adherence counseling. So sort of the twofold approach we're coming at this from. So to cover those bases and ensure that we can build a prediction model that is responsible toward patient and provider interests, I've laid out some of the steps we thought through as we're designing this work. We need to define the prediction question in the context of the overall system. We need to identify the data and structure it for the task. We need to examine assumptions about the data, train the models, examine performance, and assess the utility, trustworthiness, and fairness of any models created. So defining the prediction question, there are a lot of subtleties sometimes to get into with this. Taking the example of the potential for predicting viral load outcomes in order to support targeted viral load testing, the overarching question is, can we increase the efficiency of viral load monitoring with risk predictions? So as context for that, the guidelines in a lot of the settings we're working in, and Haiti included, recommend 1 viral load test per year for patients that are stable on ART medications, but many settings have not yet achieved this goal. There are many settings where many patients have not ever received 1 viral load test. And clearly, patients remaining in virologic failure is not good for them or for risks to population health as well. But there's a lot of challenges that come with this. There's constraints in specimen collection and transport and capacity of the national laboratory. So the questions about the best way to actually allocate testing resources are not straightforward. Do you only test the people who are at highest risk of failure, even if you already know that their adherence is poor? When the action, so it starts to be a matter of thinking through, if we make a correct prediction for this patient, what do we do with that information? If we make an incorrect prediction for this patient, what are the repercussions? And through this process, I've narrowed down sort of higher value and lower value subgroups for prediction, and still kind of fleshing that out and having stakeholder conversations to see if they concur, because I can surmise and present options, but it'll be the healthcare community to decide what the highest and most valuable use of prediction is. So stay tuned for those. The iSanté database, as I mentioned, is a little bit of a bear, only in the sense that most EHRs are kind of a bear. This screenshot is showing the process of going from a database that used to be completely custom, bespoke, developed for Haiti without originally the inclusion of standardized health codes, for example. There was quite a lot of work on the part of the team in Haiti to migrate and map the original custom concepts to standardized health concepts, so that's been very helpful. The underlying database is a pretty highly normalized relational database, and so deciding the best ways to pull information out of that and structure it for prediction tasks requires a lot of detailed decisions. There are a lot of different data types to consider. There's the continuous numeric type of data, there's categorical answers, and then there's this issue that is not often delved into in detail, but is kind of critical for understanding EHR data. And that's the difference between binary and ternary data. That's a very technical term for the cases where you get yes, no, or missing, or cases where you only get yes. So this case of where the only answer is yes and everything else is completely unknown is a much bigger factor in observational health data than in clinical trials and otherwise controlled studies. So that's a big thing to keep in mind in how we use the data. Another thing that's quite distinctive about observational health data as opposed to randomized controlled and other controlled studies is informative missingness. That often data being missing from an electronic health record system is highly correlated with something clinical about that patient. A doctor will order a test or not based on his suspicions about what is actually wrong with the patient. So there's quite a lot more work to be done in analyzing missingness in these systems as pieces of information in addition to data quality problems. This is an illustration of just how varied data capture can be in some of the sites we're working with. These are longitudinal data density plots. So the horizontal x-axis from left to right shows how many visits occurred over a given period of time. They're just scattered vertically to be able to visualize better. And the major point here is the fact that you get bands of different colors indicates that in some periods of time, quite a lot more visits were captured than in other periods of time. Sometimes this might be due to the kind of EMR outages that Nancy mentioned. Sometimes it might be due to other staffing constraints and people not having the time to enter data. So this is when I talk next about choosing methods that make as few assumptions as possible about the data. This is part of the motivation for choosing such methods. Also, another factor about observational health data is even more work going into considering how your observations got into your data set in the first place. So using the phrase data generating process for this. In this case, this is the results of an analysis to examine facility-specific factors that determine who got viral load tests. As we create prediction models that would be applied in a facility-specific setting, we need to understand whether a prediction model developed on an overall national set of data actually applies within a given facility. So understanding the factors that might drive good or poor fidelity of prediction models includes examining these data generating process differences by facility. So this diagram just shows that Viral load scheduling per guidelines, the goal of having viral load tests occur at least once a year for patients, is a strong factor for predicting when patients get viral load tested, but not the only factor. Some of the other strongly present factors are if a patient had an abnormal exam result finding, or if a patient was found to have a fever. Some of these are unique to a single site. For example, mobility in yellow came up in just a couple of sites, but this example of fever only came up in one of these example sites. And I'll also say, as a quick sidebar, this is a model that was conditional on a patient actually showing up for a visit. So this is a generalized estimating equation logistic regression model for once a patient showed up in a facility, what were the factors that drove their actually getting a viral load test? So this is not driven by missingness in this case. This is another finding at the overall national level and examining factors driving testing over time. In the orange box below, we've highlighted some of the associations showing that some of the factors that might be predictive of a viral load outcome were also predictive of decision to test. So as I mentioned before, the example of making an accurate prediction that someone with poor adherence to their medications is likely in virologic failure may not be very useful information. We see this trend that people with higher ART adherence were more likely to get tests than people with lower ART adherence, and this trend becomes more pronounced over time. It's a possibility that this is intentional on healthcare providers' parts, or it may not be intentional, but it is an association that may alter the observed proportions of failure within given subsets of patients being tested. This is a conceptual basis for putting together a prediction model. This is, in an ideal world, we would like for a prediction model to be based on causal factors and then also capture necessary statistical trends beyond that within the data. And that starts with examining what we believe is driving the actual events in question scientifically and biologically. Another feature of observational health data in electronic health records is you have longitudinal data, but it's very rarely sampled regularly. So in a study, you might have intentional time points at which you collect certain data. Ideally, we would have a viral load observation from patients every 6 months or every year, and we can compare them equally. But in our case, we don't. So what this is showing is we have some prior viral load reality in a patient. It may or may not have been observed. We have a current viral load reality in a patient that we may or may not get the opportunity to observe, but we'd like to predict what it is. In each of these cases, generally the factors contributing to that outcome are the same. There's the immune capacity of the patient, there's the properties of the virus circulating in the patient, there's the ART pressure on that viral population, how well matched is it to the aspects of the virus, etc. So these things do change over time, but they're correlated over time. So as we set up a model to examine the current state of viral load, we need to consider these time trends, the relationships over time, and the fact that we don't have data that supports very classical statistical approaches to piecing apart those different contributing factors. The methods we're currently using, there's a couple of different communities with different terminology for them. Superlearner is one in the more biostats community. Stacked ensembling is a different term that's more used in the machine learning and computer science community. It involves choosing a collection of algorithms. Often we'll choose both parametric and non-parametric types of modeling approaches. And we make predictions with them separately, and then we put them together and retrain a final, what we call a meta-learner from those base models. And we do this all in the context of cross-validation, which means a particular way of splitting data, training, and validating in rotation to estimate how well your model performs on data it was not trained on. So all of these things are, again, to minimize assumptions about the data and to try to avoid overfitting. It's not a perfect approach, it can still happen, but this method is quite robust. one of our statistical advisors has said he's had colleagues and students that have tried to break this method. They've tried to fit it with so many tests that it started to overfit, and they can get up into the many thousands of statistical tests without risk of overfitting. So that's a promising thing about these methods. Hamish, I see you reappearing. Do I need to stop sooner rather than later?
It's 12:46, so within about 7 or 8 minutes, if possible. Yeah.
Sure. All right, this is an example of some of the candidates for base models. You can have tree-based methods, which are good, solid non-parametric models. We can have some flexible parametric models, generalized additive models, even including some fairly simple models in the mix. Naive Bayes or even single decision trees is common. I include deep learning in the lower right corner to acknowledge it as a possibility, though it's typically not at the top of the list for transparency and interpretability. So trade-offs there. This is an example, again, harking back to this matter of subgroups. With considering the blue circle as our whole patient population in Haiti, we can fit an initial prediction model on this whole population and get a really great performance metric. The AUC, or area under the curve, is a summary statistic for the trade-off between the sensitivity and specificity of your model. And if your model is absolutely perfect, that value will be 1. If your model is no better than random, that model will be 0.5. If your model is showing what's called anti-learning, which is actually kind of an area of study of its own, it'll be lower than 0.5, and you should never, ever consider going anywhere near it for utility in real use. In our case, if we're predicting the whole population, we can get this great score of 0.85 or higher. But mostly what it's doing is predicting the observed virologic histories of patients. When you know what a patient's virologic history is, it's much easier to surmise what the future will be. This also doesn't add a whole lot of information to what healthcare providers would be able to operate based on as well. And so in that sense, it's maybe not the highest value of spending time and effort on making a prediction model. So looking at some of these subgroups, looking at how well can we predict only among people who are not known to have failed previously? How well can we predict among people who we have no results on? So as we start to break that down, the performance metrics may get a little bit lower, but their utility may be higher. This is an example of analyzing where a model goes wrong. So with this binary outcome, the predictions that we're making are continuous on a scale of 0 to 1. So if 0 is predicting the negative or viral load not detectable outcome, and 1 is predicting the positive or viral load detected outcome, our predictions might range from 0 to 1. And what I'm showing here is the residuals of that. When you subtract the actual outcome from the predicted outcome, having a value close to 0 is good. Correction, this is the absolute value of that difference. So having a value close to 0 is good, having a value close to 1 is bad. So I started looking at subgroups of where this is going wrong, and this is one of the models that I mentioned on the whole population that really mostly just predicts the virologic history. So showing that in this particular model's case, we may not be adding a whole lot of information beyond showing that the people that have failed before are more likely to fail again, and the people that have not failed before, the model that's in the right panel, the blue distribution on the far right. Those are the people that have not failed before, but did fail in our training data. And this error analysis just shows that one of our initial models was really not very good at separating those people out. So it sends us back to the drawing board to try to tease that out better. The matter of assessing subgroups is applicable not just for model performance, but also model fairness. There's quite a bit of concern, especially with observation. Pardon?
About 5 minutes.
Yes. There's quite a lot of concern, especially with observational health data, that less than ideal patterns of care captured in the data might be perpetuated unintentionally by a model. Depending on how you set up your predictive factors and the way you train your model, you may be training your model that less than ideal patterns of care are what should be replicated. So there's quite a lot of work to figure out quantitative methods of assessing fairness, and they're quite challenging. There's quantitative methods at the group level and at the individual level. So at the group level, you declare a subgroup or a sensitive group and say the quality of predictions in this group should be no worse than the quality of predictions overall or in another group. in the individual fairness methods, there's the idea of individuals with similar characteristics should receive similar predictions. The challenge is you can come up with a lot of thought experiments where group level fairness looks great, but is actually a matter of subgroups within that getting very, very different treatment in a problematic way. Individual methods require some pretty strong assumptions about the nature of data capture in your data set that I mentioned earlier as the data generating process. So the jury is still out on the best way of addressing this, but it's still very good to go through these conversations and especially to discuss with stakeholders what we need to be on the lookout for fairness. What are the values and the priorities that we need to make sure our model supports? So with that, this is just a nod toward the fact that along with all the quantitative work, we're also pursuing qualitative work with our stakeholders in Haiti. We've recruited healthcare professionals and policymakers to weigh in on the current state of viral load testing, adherence counseling, and regimen switching in Haiti, what their vision of ideal would be, what the barriers to that ideal are, and then in a future state, we'll present some of the different ways that the findings of a prediction model could be shown within the EHR, anything from just simply showing summaries of information to showing actual predictions with directives of do test this patient, don't test this patient, do provide adherence counseling, et cetera, and seeing what providers' preferences are. And with that, I will stop. We have so many people to acknowledge in this work. We have many collaborators in Haiti, here at Brown, and other universities, and are very grateful to all of them. And I'm very grateful to you for attending the talk. So I would love to hear any questions.
Okay, so thank you so much for that really great talk, both of you. Really interesting work, and I think very relevant to this particular lecture series. So I'm just looking to see if we have any questions from the audience. And so if you're interested in asking a question to the speakers, please type that into the chat window and I'll read that out and address that to them. So meanwhile, I had a couple of quick questions about your work. So one was that when I looked at the difference of difference analysis, it seemed like in the first one, one of the challenges in reviewing that was that you had two different sites that you were studying, but the control site had actually started off at a better level of adherence. Is that right? That was addressed to Nancy.
Yeah, Hamish, that's right. But that's where the difference in difference model is attempting to use that historical data to detect, over and above whatever trend was observed in that control site, what change did we see in the intervention site? But again, with only two sites, it's fairly limited. There could be other things that could explain that difference in difference.
Okay, yeah, no, I mean, I looked at it for a moment and I realized that's what was going on. I think it's a very good approach when you aren't able to do a full randomized controlled trial, but it takes a little bit more interpretation, doesn't it?
Yeah.
Okay, let's see any other questions from the audience at the moment. Another 5 minutes or so. So another point, I think, just to address that to Tracy, with the last part of your work talking about potential biases, that, I mean, it's obviously a very critical question in machine learning and prediction modeling, and we're perhaps more cognizant of that in some ways in a country like Haiti, where we know that there are so many different groups who have such strong barriers to getting access to care. And I wonder if you had any examples of where you think that the data collection was potentially biasing that. Is it an issue of certain groups not getting regularly seen and therefore not getting data into the EHR?
Yeah, it's a challenge in our data to be able to dive into aspects of fairness that we would really like to, but are not captured very well in the data. We don't have a lot of data on key populations. We don't have a lot of data on socioeconomic status. We do have the ability simply to look at who has a lot of data in the system and who does not. So when you consider how well the model works for people that either have not been seen as frequently or are seen at a facility that collects less data, yes, we do have less ability to make predictions for them accurately than we do for people that have a long history of robust data collection at a facility that is staffed well enough to capture all of it. And that is an inherent unfairness of the system, that it works better for some of these settings than others. And that's another one of those stakeholder questions for them to weigh in on is it is it helpful or not to use an approach that serves some areas better than others? So it's certainly an open question.
Do you have any data from community healthcare workers with or without sort of mobile data collection devices to give you a little bit better sense of those patients that are less seen in the clinic?
That would be a really great future study design. It's not something that I would currently be able to include. That would be really interesting.
Okay. All right. I'm not seeing any other questions from the audience. I assume I should be able to see those in the chat window. Oh, okay. All right. Well, I think if we aren't any further questions, we'll just say thank you so much for this two really interesting talks, obviously two linked talks, and really appreciate your time you put into this, and wish you good luck with your next stage with this study, because it's obviously going to be very important to the patients.
Thank you so much.
Thank you very much. Pleasure to be with you.
Bye.